Assalamu alaikum. This is the lecture called the Gluteal Region, and this is part of the anatomy of the lower limb. I am Dr. Al-Abbasi, teacher in Muslim University College of Medicine. And I will take you today in this very important regions that have many clinical importance. Now, to start with, we will have a study about the skeleton of the gluteal region. And as you know, that the pelvis consists of three bones. So those three bones, let me do the laser. So the three bones here, we have the pubic bone, we have the ischium, and we have the ilium. And they are all united to be coming in one region called the acetabular fossa. Now, this skeleton will be completed by ligaments, very tough ligaments. So those that you can see in blue. Now those ligaments, we will see this one. This is the biggest one, and this is starting from the ischia tuberosity, okay, to the sacrum. So it will be, it's called sacrotuberous. So from the tuberosity of the ischium and then to the sacrum, sacrotuberous ligaments, and this is like a curvy one. Now there is another one traverse this, so it's like mainly in the middle, and this is again coming from the spine here. It's called ischia spine. It was just a very sharp bony prominence in the ischium bone, and then it will go to the sacrum again, anteriorly and laterally. And this is called sacrospinous ligaments. Now, if you look to this, so this cavity was a cavity that have a wide extension, but this have been limited by those two ligaments. Now, this will form like a reverse B-shaped letter, or actually it's have been dividing this space into two foramina. Now the biggest one here, which is the upper one, called the greater sciatic foramina, and the lesser one, or the below one, is called the lesser sciatic foramina. Now those foraminas are very important for us. That will come later. Now, as I mentioned, this is very tough ligaments, so it's like it's acting like a bone. Now there is another membrane here, fibrous membrane. It's called the obturator membrane, and this will enclose closing the gap here between the ischium and the pubic bone, but it will leave a very small window, if you like. It's called the obturator canal, and we will see later on what this obturator canal will benefit us. Now, so if you look posteriorly to the pelvis, and then you have to the two hip bones, ilium, pubic bone, of course, anteriorly, and the ischium. Now, ischium, this is the bone you sit on. So when you sit, this is the bone you are sitting on. And then you can see this completing the picture of the bones, which with the ligaments. Of course, we have supraspinous ligaments, we have iliolumbar ligaments, we have posterior, superior, like iliac spine, and there is a ligament attaching to it. It's called the sacrotuberous ligaments here. So this is sacrotuberous. Very tough ligament, posterior sacrococcygeal ligaments, many ligaments. You don't need to worry about the names, but you can see how the structure is doing this. And from those ligaments, you can imagine now how this space, open space, will be closed except for the greater sciatic foramen, and of course the lower down, which is here, which is the lesser sciatic foramen. This is a posterior view, and from these you will have many structures going out and going in those foraminas. So it's either going out to be in the lower limb or going in to be inside the pelvis. Now, important. We are talking about the role of a gluteal minimus and medius. Are they important to us, and what is the importance of each? Those two help us in walking. Now we will divide the muscles of the gluteal region into two groups. This is a more structural division. So the first one here is called the superficial group. Now, superficial group consists of three main muscles. They all called gluteus. We have a gluteus maximus here in the red, we have a gluteus medius in the green, and we have a gluteus minimus, and this is in yellow. Now, the deepest is the gluteus minimus, above it is the medius, and the overall is covered by gluteus maximus. Sometimes we can add to those is the tensor fasciae lata, which is a more anterior muscle here. It's going like from the anterior superior iliac spine. So they added to this superficial groups because it's a help or it's assisting its action. Now, so the muscles here, this is the gluteus maximus. This is the largest here. Its origin is from the ilium behind the posterior gluteal line, dorsal surface of the sacrum, of course, and the gluteal aponeurosis. It will be inserted into a tract here. This is a fibrous tract on the lateral side. It's called the iliotibial tract. And of course, it will attach as well to the gluteal tuberosity of the femur, deep. So this is a tract, as you can see here. Okay, and so lateral side, this is help you to extend the knee. So extending the thigh is the main function of this iliotibial tract. If you have a weak iliotibial tract, your knee will be bent, so your thigh will not be as extended. This tract is from the iliac crest lower down to the fibula, to the bones of the leg. And you can see there's two muscles attaching to this, the gluteus maximus that we mentioned, and then the tensor fasciae lata. This is the tensor fasciae lata here. So two muscles joining to help and assist this iliotibial tract. Before going to the what we call finishing the superficial group, we have this those two. Still we have the superficial group. We have the gluteus minimus, and the gluteus minimus start from the ilium between anterior and inferior gluteal line. That will be show you in the practical lab. And the gluteus medius, which is cover it, again it's from the ilium between anterior and posterior gluteal line. They all inserted into the greater trochanter of the femur. Those acting are like the same function. They abduct and rotate the thigh medially, and they help in flexing and rotating the thigh medially. So abduction, rotation medially, flexion, rotation medially. They help us in walking, and we will see later on how they can stabilize the hip. Now, so if we go further into the deep group, you can see in the deep group we have several muscles that are arranging like in horizontal plane. So starting from here, which is the greater trochanter of the femur. So most of them are attaching to the greater trochanter. Of course, this is their insertion. But I will enumerate them from above down. So above the all, we have the piriformis. And the piriformis starting from the pelvic surface of the sacrum, and then go to the greater trochanter. And below the piriformis, we will have the superior gemini. There's a very small muscle here. Now, going down, we have another muscle here. It's called obturator internus. And then you can see the belly of the muscle is actually inside, is taking the pelvic surface of the obturator membrane and its adjacent bone. And you can see maybe mainly the tendon of it is in the gluteal region. Very small tendon. Below the obturator internus, we can see the inferior gemini. And the inferior gemini is starting from the ischial tuberosity here. And of course, it will go to the obturator internus tendon. It will be inserted here and then to the greater trochanter. Now, the final one, the last one here, this is more quadruple shapes called the quadratus femoris. And the quadratus femoris is starting from the ischial tuberosity and then to the intertrochanteric crest of the femur. So those are 1, 2, 3, 4, 5 muscles that's arranging in rows starting from above them. So what's their main function? Because they have a very common insertion, they all laterally rotate the thigh. So the main lateral rotator of the thigh are those: the piriformis, superior gemini, obturator internus, inferior gemini, and the quadratus femoris. On the contrary, what are the medial rotators? Those are the gluteus medius and gluteus minimus. So they are medially rotating, so counteracting each. Okay. So of course you can memorize all those muscles looking to the table. It's better to study muscles using tables rather than using text. So tables with pictures. Now I will talk here about the Trendelenburg sign. This is mainly the action of gluteus medius and minimus. Now, Trendelenburg sign is an important sign that can give you an idea about the action of the muscles, how they are acting actually. So what you do, you ask the patient to stand on one leg. Now, normally when someone standing on one leg, let's say he's standing on the right leg, so the left side will be unsupported. So standing on the right, lifting the left. So what should happen, which is normally happened, is actually your pelvic or your iliac crest will be at the same level because you have muscle contracting on the other side. Okay, if you have, this is a negative Trendelenburg. If you got a pelvic drop, which will occur on the unsupported leg, that the leg you lifted, يعني اللي انت رفعتها, the pelvic drop can be recognized the level of the iliac crest. So if you have a right gluteal muscle weakness, okay, the right side is weak because of nerve injury, probably the superior gluteal nerve. Okay, the left side of the pelvis will drop when the patient stands on its right. So you have the right, okay, and then you have a left drop. The left leg is unsupported. Let's show you this in picture. These are the gluteus medius and the gluteus minimus and medius. So what we have here, now we ask the patient, this is the B patient is the normal patient. So this patient is standing on his right leg, okay, and lifting the left. So when those abductors, okay, and medial rotators acting, they lift, they preventing this side from dropping. so they act, they contract. Now what happens if this right side is weak because of the superior gluteal nerve palsy, superior gluteal nerve injury? So those are weak. So when the patient stands on its right, the left side will drop because they don't have this action of the traction of those muscles where to abduct, okay, and of course medial rotate. So that we call this is a positive Trendelenburg sign. So if the patients have this on both sides, like weakness of those two, he got what we call a waddling gait. يمشي مثل البطة. Now another important thing here is, which is very important clinically. I think you answer this question in the assignment in the Google Classroom, is where to give injection. Now, of course, we have many sites of injection, like the deltoid, upper arm, but the most common is you inject in the gluteal region. Now, the gluteal region here, so we will see this is in A here. So deep relation with gluteus maximus, you can see there is a nerve coming here. This is a sciatic nerve. We will mention it later on. So the sciatic nerve is actually exiting inferior to the muscle piriformis. Okay. So if you divide the gluteal region into like 4 quadrants, so so you put like this quadrant here, okay. What we will have here, we will have like they call it upper lateral quadrant, upper medial quadrant, lower lateral quadrant, lower medial quadrant. You should avoid those quadrants here, like the lower quadrant. So your injection will be in the upper outer quadrant, and this called superior lateral quadrant of the neck is free of nerves and vessels, and is frequently used for intramuscular injection in order to avoid the sciatic nerve and other important structures that we will mention later here, vessels, arteries mainly, and of course nerves. An alternative site is over the gluteus medius in a triangle area bounded by the anterior superior spine and the tubercle of the iliac crest, like here. So it's like a small window here. Maybe we can use it for female, pediatric age group, but most probably we have this very large area here. So this is your site in the upper outer quadrant of the gluteal region, trying to avoid all these neurovascular bundles in this site. Yeah, that's you should be careful with. Of course, there are measures with the sciatic nerve going. So the sciatic nerve is starting. If you take a line from the ischial tuberosity to the posterior superior iliac spine, and then you have like 2.5 centimeter of this, like 1/3 of it, and then this is your origin of the sciatic nerve. This is surface anatomy of sciatic nerve. And then you take another line from ischial tuberosity to the greater trochanter of the femur, and in the mid, this is the course of the sciatic nerve, origin course here. So yeah, try to avoid these areas. Sciatic nerve is so important. It's the main nerve supply of the lower. So we will describe to start with is the cutaneous nerve supply. And you can see this is a very demonstrative illustration. As you can see, different colors, different nerves. So this gluteal region area on the skin, it's mainly supplied by L1, L2, or 3. And this is from the superior, they call it cluneal nerve, posterior brainwire. Of course, this is more medial and around the anal region or upper medial side of the thigh is supplied by S1, S2, S3. patients developing this kind of paresthesia خدر، فمعناها انه ال L1 L2 L3 is affected. إذا حس هذا الخدر لا بالمقعد أو ألم، فمعناها ال S1 S2 S3 is affected. If you go to the lateral side here, this is like lateral cutaneous nerve of the iliohypogastric nerve, and this is from T12. And then we have on the majority of the lateral side اللي هو نفس المنطقة مال iliotibial tract, you can see lateral cutaneous nerve of the thigh, okay, is supplying this area. Now most of the thigh area here, which is the hamstring area, if you like, is supplied by the inferior cluneal nerve, which is a branch of the posterior cutaneous nerve of the thigh. That leave you with a very small obturator over the obturator muscles called the cutaneous branch of the obturator nerve. So this is the cutaneous nerve. Now all these nerves are coming from sacral plexus, and I think you are familiar with this. So I have lumbar plexus, sacral plexus, and the coccygeal plexus. And here, as you can see, from the lumbar plexus we have the lateral femoral cutaneous nerve, the femoral nerve, obturator nerve, and genitofemoral nerve. Of course, in the T12 you have subcostal, L1, iliohypogastric, ilioinguinal, and then you have the sacral plexus, and the sacral plexus coming from L4, L5, S1, S2, S3. Now those nerves will, of course, it will give roots here, and then main trunk, and then it will give you the nerves. Now the largest you can see here is the sciatic. The sciatic nerve is actually two nerves coming together. The first one's called common peroneal, and the other one called tibial. Each one's coming from different nerve roots. And I think if you go to your tables of nerves, you can see and you can know which root is the tibial is coming from, which root the common peroneal nerve is coming from. Or you can see this picture here, very demonstrative picture. And then we have superior gluteal nerve and the inferior gluteal. Superior gluteal, as we mentioned, this is for the gluteus medius and minimus. The inferior gluteal is for the gluteus maximus, as we will see later. Sciatic nerve relations is so important. This is the pictures that we show about the greater sciatic foramen, structures going out, lesser sciatic foramen, structure going out and in. So we will study it now in details. Now, the arrangement of those structures, this is the piriformis, this is your key muscle here. The arrangement of the structures emerging from the greater sciatic foramen, which is actually the foramen that gives exit to the piriformis. It will give 7 nerves. Okay, 7 nerves exit. So they are sciatic, posterior femoral cutaneous nerve, superior gluteal, inferior gluteal, pudendal, nerve to the obturator internus, and nerve to the quadratus femoris. 7 nerves exiting from the greater sciatic. Okay, رقم 7. Sciatic, posterior femoral cutaneous, superior gluteal, inferior gluteal, pudendal, nerve to obturator internus, and nerve to quadratus femoris. Now, and it will give as well arteries. Those arteries are the internal pudendal artery. You have the superior gluteal and the inferior gluteal arteries. Superior gluteal, of course, above the piriformis. Inferior gluteal is below piriformis. 3 arteries. Now, the nerve to the quadratus femoris and the veins that accompany the arteries are not shown here, so they should be here, so we can see it in other pictures, maybe in your atlas. And then you have those structures that is going back through the sciatic foramen. And those structures are the pudendal nerve, the internal pudendal artery, and nerve to obturator internus. 3 structures here. Going in more, this is a more a very nice section, oblique section. This is the oblique section here. And now what you can see the gluteus. Of course, this is the maximus, medius, minimus. Those are supplied by the superior gluteal nerve. Their blood supply is the superior gluteal artery. Then you have the gluteus maximus here. Mainly, its main supply is the inferior gluteal nerve. Of course, this is supplied as well with arteries called inferior gluteal artery. And then you can see this is the piriformis. This is the key muscle. Is going out from the greater sciatic foramen. 7 nerves are going out, 3 arteries we have, and a muscle. And then you have those 3 structures going to the inside. Okay. Same 7 nerves going out, as we mentioned, and 2 arteries and 2 nerves as going outside. So sacral plexus, so superior gluteal nerve is coming from L4, L5, and S1. It will pass through the greater sciatic foramen immediately superior to the piriformis. Inferior gluteal L5, S1, S2, so this is lower down level, traverse the greater sciatic foramen and just inferior to the piriformis. Now, of course, we have the pudendal, and pudendal is passing through the gluteal region. Just appearing in the gluteal regions doesn't supply anything in the gluteal regions, and they re-enter the pelvis through the lesser sciatic foramen. Now, posterior femoral cutaneous, which is S1, 2, 3. They pass posterior through the greater sciatic foramen, just inferior to the piriformis, and descend to the gluteal maximus. Continue as the middle of the posterior thigh, as I show you in this slide, with the cutaneous nerves. The largest nerve in the body is the sciatic. Now you are looking now to the sciatic here. As we mentioned, it's 2 parts, tibial and camfibular. They are bound together and then separated. When they're separated just above the popliteal fossa, which is an area just behind the knee joint. Now, the sciatic nerve, which is coming from root value L4, L5, S1, S2, S3, they traverse the greater sciatic foramen below piriformis, so the piriformis here, just below piriformis, and the fibular component, however, which is the lateral one here, may pierce the piriformis sometimes, or emerging sometimes superior to it. So there are variations. The sciatic nerve will descend under cover of the gluteus maximus here, and then along the middle of the posterior thigh, in terms of the surface anatomy, sciatic nerve leave the pelvis a little more than a third of the way along the line, the posterior superior iliac spine. Okay, and then descend about halfway between the ischial tuberosity and the greater trochanter. Right, and then going up. Now, accompanying this is as you see now, we have the femoral artery here, and the femoral artery is more anterior, and then going maybe the same course, but this is anterior, this is posterior. Okay, and posterior, anterior, doing the same course here. This is more, and then it's divided again into 2 here. So there's a popliteal artery and a very small artery is on the medial side, so it will pierce the fascia here and going posteriorly. So they will be in the same fossa here. Okay, popliteal artery is coming from the femoral artery. So there are resemblance between the anterior and the posterior part in terms of the sciatic and the femoral artery. Now we have this examination that we do to see if there is any sciatic nerve irritation. It's called the straight leg rising test. So patient is supine, we start to rise the leg, and if pain developed here, this is morely irritation because we are stretching the sciatic nerve. There's irritation of the sciatic nerve. So this is called a case called sciatica arganisa. This is a very common test we use in examination by stretching the sciatic nerve, and the root of the sciatic nerve is irritated, meaning there is a disc prolapse, there is a problem in the back of the patient. Now, we will talk in brief about the this network of arteries here. Of course, the gluteal arteries arise maybe directly or indirectly from the internal iliac artery. So there are branches of the internal iliac artery. We will have the superior gluteal here. So as you can see, the superior gluteal artery here, this is the left side of the artery, is coming from the internal iliac artery. Okay, so this is the largest branch of it, accompanies the corresponding nerve. So the superior gluteal nerve is with it in close relation, and they're coupled with the gluteus maximus, and it will divide it into branches that supply the gluteal muscles. On the other hand, we have this inferior gluteal, again as a branch from the internal carotid, iliac artery, accompanies the corresponding nerve. There's inferior gluteal nerve, okay, supplying the gluteus maximus, and under cover of the gluteus maximus lies medial to the sciatic nerve, to which it gives a companion artery. So the inferior gluteal artery will contribute and will share with the blood supply of the head of the femur. Superior gluteal is just for muscles, not for joints. Now there are veins, and veins are usually accompanying the arteries, and they drain into the internal iliac vein. So they correspond with the same names, with the same relation, with the same side to the arteries. Veins can return the blood from the lower limb even when the femoral vein is ligated. So they are independent of the femoral vein. Okay. And by this, actually, we finished the gluteal region. What is important in the gluteal region? It was the muscles, superficial and deep group. It was the relation of the nerves and the nerves emerging, and of course the arteries or the networks of the arteries there, plus the continuous nerve supply of the region. Thank you very much.